So I think understanding the current process and the healthcare delivery of a geriatric assessment is highly pivotal to how we're being able to improve the care for older adults with cancer as a whole, with both patients with multiple myeloma and really any cancer. And it's relevant because how are we going to systematically deliver this? Well, in some facets, some of it's quite readily available. We don't currently assess for patients who have cognitive impairment, but embedding those types of tools into your clinic is fast, quick, and efficient. In myeloma particularly, we have the International Myeloma Working Group frailty calculator, which can be readily done based upon three indices, which is age, activities of daily living, instrumental activities of daily living, and the Charlson Comorbidity Index. This is quick, easy, takes less than 5 minutes. There's also the revised Myeloma Comorbidity Index, which also can be done to be able to identify deficits that are associated with aging. But how do we meaningfully impact these assessment tools and also intervene upon them is really critical to understanding what a geriatric assessment is. We both need to identify the risk of the risks that are in the tools, but also to intervene upon those deficits using healthcare delivery. And I think that's where we really struggle as oncologists, is how do we both assess the cancer-related needs as well as the age-related needs. And I think that's where we can work with geriatricians, we can use to assess the knowledge in our clinic is really pivotal. So in terms of the geriatric assessment, what variables matter the most? I think when we think about that, we think about the 4 cardinal domains of a geriatric assessment. We will look at physical function, and so how can we do that readily? Well, the short physical performance battery is a well-studied tool. An assessment of gait speed is very easy and quick to do in your clinic, or something as simple as a time get up and go. These tools are readily available, and it's as simple as a vital sign, and I think we can embed that readily into our clinic. But there are other things that also need to be evaluated in order to be more comprehensive about that approach beyond physical function. It's assessing the severity of their comorbidities and what needs to be modified or what we can intervene upon to optimize those comorbidities. Understanding psychological well-being and also looking at caregiver needs at home, I think, is really relevant for the older adult. And those things need to be assessed the same way in multiple myeloma as we would look at cytogenetics for their bone marrow or a skeletal survey. So if we really think about that as being pivotal to their diagnostic strategy and to be able to best optimize older adults with cancer over the care continuum is very relevant.